Hello everyone, welcome to Surgtest. Let us go ahead with yet another session on the lectures for your exam based on your NEET exam, mainly for your surgical aspect. This class would be on cutaneous malignancies. I, Dr. Samanth Kumar, would be taking this class on skin malignancies or cutaneous malignancies for you so that you can answer your questions in your exam. So, coming to the introduction of these cutaneous malignancies, or per se the skin per se. You see, the skin is the largest non-visceral organ and it is made up of epidermis and dermis. Epidermis constitutes about 5%, whereas the rest of the thing is only dermis, which is around 95%. Most often asked question is, what is skin adnexa? You see, skin adnexa, they are nothing but your hair follicles, your sebaceous glands, and your sweat glands. Sebaceous glands are holocrine secretions. Sebaceous glands, they produce holocrine secretions. That is to say, the secretions of these glands are mainly the complete cell itself. So the cell degenerates completely and thereby is produced into the secretion as a whole. So that is a holocrine secretion. So basically the sebaceous glands are producing holocrine secretions. The other types of glands in skin are your sweat glands, and these sweat glands are of two types. One is a simple eccrine gland and the second one is an apocrine gland. You see, eccrine glands are those glands which secrete their secretions into the lumen to which they form a part. Usually they'll secrete your sweat, etc., into the tube or the lumen which comes onto the surface. As you can see in this diagram, you see these are the sweat glands and these are the simple eccrine sweat glands which will produce their secretions which are poured into the lumen of the duct or the duct, okay, and they are at last produced onto the surface of the skin. So these are the simple eccrine sweat glands. The other kind of sweat glands are apocrine glands. This is to say that these glands, the cells of these glands, the uppermost portion of these cells, they get denuded, which contains vesicles containing the secretions. Rest of the cell remains the same. Okay. However, the tip of the cell sloughs off and is produced into the secretion. So since a part of the cell is present in the secretion, these are acted upon by the bacteria, and which produces a special kind of odor or aroma to the secretion. So that is how these apocrine secretions or apocrine glands producing these secretions, which are mainly present in your axilla and groin, okay, they produce a peculiar smell to the given person, okay, and usually they will become active only during puberty or after your puberty. So this is regarding the skin adnexa and skin and their adnexa. Quite a few small questions only are expected from these, which I have already covered. Okay, coming to the blood supply of the skin, this is very important because you see, anyhow this will be covered in your plastic surgery classes, but still you see the blood supply for your easy understanding comes from the feeding vessel, which is mainly subfacial vessel. This later on transforms into the facial vessel. Okay, these facial vessels give a lot of many subdermal vessels, and these subdermal vessels, they form plexuses in the derma or subderma, and from these subdermal plexuses, few vascular twigs, they still sprout above, forming the subepidermal plexus. So this is how the skin gets its nourishment. The epidermis has got no blood supply of its own, no blood vessels of its own. So the nourishment of the epidermis entirely is dependent upon the diffusion. Okay, so what you have to here understand and remember are these various steps of, or the various ladder upon which the blood vessels ramify, ultimately supplying the epidermis. So they are the subfacial, followed by facial, followed by subdermal, followed by dermal, and then lastly subepidermal. Subepidermal. Okay, this is very much evident in the diagram that I have put here. Okay, another important thing that you have to remember is regarding the blood flow to the skin. You see, since the skin is the largest organ, much of the blood also goes to the skin. Okay, and the amount that goes to the skin varies between a variety of range. You see, it goes somewhere around from 5 ml to around 100 ml per 100 grams of tissue per minute, and this is taken up within a wide range of temperature, which is from 20 to 40 degree centigrade. Okay, and this, why this wide range is required? You see, this wide range is required to meet the metabolic rate and to maintain the temperature. So the potential of this 20 to 100 times between the lowest and the highest range of blood supply that is met into the skin is mainly to meet the metabolic and thermoregulatory requirements of the skin. Okay, another important point that you have to remember is regarding your choke vessels. As I've shown here, you see the choke vessels can be present in various strata of these plexuses that I have already mentioned, but most commonly these choke vessels, they are within the muscle. Okay, as evident in this diagram, let us say you have two angiosomes, angiosome A and angiosome B. Okay, angiosome is nothing but a specific part of skin which is supplied by a defined vessel or a named vessel, let us say. Okay, and most of the flaps, they are dependent upon these angiosomes. Okay, a single flap may be a single angiosome, or it can be a combination of angiosomes. In this example, let us say you have two angiosomes, angiosome A and angiosome B, and both of them are of like two different flaps, let us say. Okay, but let us say a requirement has come wherein you are basically planning with angiosome A, a flap based on angiosome A, but the defect is such a large defect that which will require even inclusion of the nearby angiosomes, like here in this case angiosome B. Okay, but the arc of rotation depends mainly upon the vessel supplied by angiosome A. That is to say, you have to cut the blood supply to angiosome B, then only the flap will turn over to the required defect. Okay, in that case, what you do is you try to ligate or try to divide the blood supply to the angiosome B. What will you achieve by this? If you do this, then the choke vessels, which were, let us say, dormant until now, they open. Okay, so these choke vessels, they open and they start supplying the angiosome B from the blood supply of angiosome A. Okay, so this is the importance of these choke vessels. Okay, I think I have made myself clear regarding the choke vessels, and I think you can answer the questions if at all they have asked you regarding choke vessels. These choke vessels, they form the primary basis of what do you say, delay. You say flap delay. There is something called flap delay. They are called, like, let us say there are examples like DP delay. Okay, deltopectoral delay. The deltopectoral flap will be there, and if you want to harvest much more than the range of the deltopectoral flap, you do what is called a DP delay, wherein you try to ligate the blood supply of the nearby angiosomes, thereby opening the choke vessels, and then you wait for some time until the choke vessels open, the flap regains its blood supply completely, and at a later date, you take a larger deltopectoral flap. So this is what forms the basis of your delay, DP delay or flap delay. Okay, so this is regarding your choke vessels, which are mainly, for your exam point of view, you have to remember they are mainly present within the muscle. Okay, but they can be present at various strata of the above mentioned blood supply ramifications. Okay, coming to the next most commonly asked question, but most commonly mistakenly understood. Okay, you see the functions of the skin. Okay, you see the skin forms a barrier. It regulates the temperature and also water. Okay, what important is this excretory functions of skin, which are like it excretes urea, sodium chloride, potassium, water we know, and what you have to remember extra is sulfur. Okay, apart from them, skin also produces vitamin D. So it has an endocrine function of producing cholecalciferol or vitamin D, and also a metabolic function of producing the androgens. Okay, and the other important function that you already know is the sensory function of the skin. So it helps in touch, pain, temperature, and pressure perceiving. Okay, so with this background, let us say not much more questions will be asked from the most basic parts of your skin. Okay, so let us go ahead with the cutaneous malignancies. And for your better understanding and for easy remembrance, you see I have divided these cutaneous malignancies into two broad types, which are melanomatous skin tumors and non-melanomatous skin tumors. Okay, and these non-melanomatous skin tumors, they are constituted mainly by your squamous cell carcinoma and basal cell carcinoma. Basal cell carcinoma is the most common cutaneous malignancy. Okay, among all the cutaneous malignancies, basal cell carcinoma is the most common cutaneous malignancies. Okay, the other non-melanomatous skin malignancies that I'll also discuss in this session are your Merkel cell carcinoma, okay, dermatofibrosarcoma protuberans, extramammary Paget's disease, Kaposi's sarcoma, and cutaneous angiosarcoma. Okay, so these are regarding the broad classification of cutaneous malignancies that you have to remember. So going ahead with the discussion regarding your malignant melanoma per se. Okay, so malignant melanoma forms only 2% of the skin cancers, but yet it forms 80% of the deaths. So it forms the much bulk of the deaths caused due to skin malignancies. The important point that you have to remember in malignant melanoma is the rate of the second primary melanoma. That is to say, a patient or a person who has already suffered with malignant melanoma is always at a risk of getting another malignant melanoma or a second primary melanoma and the risk is around 6 to 7%. And the risk is highest in the first 2 years of the diagnosis of the previous malignant melanoma. However, the risk remains elevated until 20 years. Okay, so this is one important point that you have to remember, that the risk is highest within the first 2 years, but the risk remains elevated for up to 20 years from the diagnosis of the initial malignant melanoma. 10% of the melanomas are familial. Okay, and the most common familial syndromes associated are your FAM, your dysplastic nevus syndrome, and xeroderma pigmentosa. Okay, not to our surprise, you see malignant melanoma is the tumor which has got the highest rates of somatic mutation per megabase pair DNA. Okay, and this could be because we have probed into the understanding of the cancer mainly because of the study of all the mutations taking malignant melanoma as a baseline tumor. Okay, but however, as of now, until now, the tumor which has got the highest rate of somatic mutations per megabase pair DNA is malignant melanoma, most probably because the reason being that we have been studying thoroughly the malignant melanoma as a primary tumor among all the other tumors. Okay, the most common benign pigmented skin lesion is seborrheic keratosis. You see, malignant melanoma is a pigmented skin lesion and it forms 2% of the skin cancers, but yet it is not the commonest pigmented skin lesion. This commonest pigmented skin lesion is a benign pigmented skin lesion, and the commonest benign pigmented lesion is seborrheic keratosis. Okay, the Other name of malignant melanoma is cancer noir. Okay, it was basically called so because it was thought to be a black cancer. It was thought to be a black cancer, but however, when actually you see, though they say melanoma is a black pigment, okay, but most of the people, brown people, okay, most of the brown people, they have melanin, okay, to your uh, understandable levels. Okay, if the melanin pigment becomes much more, then usually they become much more darker brown, and then only a blacker tinge comes. Okay, at the same time, if you go into the lymph nodes of the melanoma, they will be brown in color rather than black in color. Okay, but still, though it is brown, okay, though it is brown, the name of malignant melanoma, since melanoma means black, is also a cancer noir or your black cancer. Okay, it is just another name that you have to remember so as to not lose your mark. Okay. You see, malignant melanoma is common in males, and the prognosis is slightly better in females, understandably, yes, because this incidence is less in females, the prognosis is usually better in case of females. Okay. However, the important point that you have to remember is regarding the site. You see, in case of males, the most common site is the back of trunk and head and neck, whereas in females it is the lower extremity, and that too more common below the knee. Okay, the malignant melanoma in case of females is more common below the knee. Okay, another important point regarding the epidemiology is regarding the prevention. You see, malignant melanoma has got a lot of preventive measures. Okay, but until now, the time-tested preventive measures, among the time-tested preventive measures, no direct, you see, these are all epidemiological studies, and there are no direct randomized controlled trials. So with the data that is available, you see, avoiding exposure to the sun to a greater extent, that is keeping yourself indoors, that is building, is a much more effective way of preventing malignant melanoma. Okay, this is followed by clothing, and this is followed by using a sunscreen. Okay, an important point that you have to remember is regarding the sun protection force. You see, SPF in most of the creams, okay, that people use as a sunscreen, you see, they will be mentioning something called the SPF factor, that is the sun protection factor. Okay, a sun protection factor of 15 decreases the risk of malignant melanoma by 73%. Okay, yet, but still, the use of sunscreen is not as good as keeping yourself indoor. Okay, so this, in this slide, what I want you to impress upon is regarding the effectivity. Keeping yourself indoor is much more effective than a good clothing, than sunscreen. Okay, the degree of pigmentation of skin is a relative protective factor against melanoma. That is to say, people who are white and fair, those who have less amount of pigmentation, they have much more risk of getting malignant melanoma rather than browns and blacks. Okay, coming to the etiology, as you all know, you see, there are a lot of etiologies, but however, the most important etiologies I have highlighted. Okay, so the most common or the most discussed etiology is ultraviolet. Okay, what you have to remember regarding this ultraviolet rays is that intermittent exposure to intense UV radiation alone is a risk factor for production of malignant melanoma. This is not true for squamous cell carcinoma, wherein the cumulative exposure is important. Okay, in case of squamous cell carcinoma, you see, in case of squamous cell carcinoma, cumulative exposure is important. Okay, whereas in malignant melanoma, the risk of malignant melanoma is when you have intermittent intense exposure of UV radiation. Mainly that happens in tanning beds wherein UVA exposure is more. Okay, and in case of sunburns, these are mainly caused by ultraviolet B. Okay, and as the second etiology, as I've already told you, the physical trait, you see the Caucasians, those with blonde red hair, light skin, blue eyes, and those who are inability to tan. So these are the people who have the risk of malignant melanoma. Okay, but yet the most important etiological factors are, as I've already told you, a previous melanoma. As I've already told you, 6 to 7% risk will be there. Okay, and the second important etiology is the familial predisposition, and the third most is the previous benign nevi. Previous benign nevi. Okay, and the point that you have to remember regarding this benign nevi are, if they are more in number, let us say more than 50, and they are of big size, let us say more than 2 millimeters. Okay, these subset of people, these are the one which are at high risk of getting malignant melanoma. Okay, the other benign skin lesions like your Fitzpatrick skin types 1 and 2 are also a risk factor for malignant melanoma. Apart from these, immunosuppression is an etiology. Okay, occupational exposure to your coal tar, arsenic, and radium are a risk factor. Okay, and important drugs that I want you to remember as a risk factor for your malignant melanoma are your voriconazole, sildenafil, and TNF inhibitors. Okay, it is sufficient if you remember these three drugs, because these will be coming again and again in your squamous cell carcinoma topic also. You see, so the drugs which are commonly associated with the formation of malignant melanoma, these are voriconazole, sildenafil, and TNF inhibitors. Okay, not only drugs, you also have diseases like Parkinson's, prostate cancer, and endometriosis also, which are associated with the malignant melanoma. Coming to the pathogenesis of malignant melanoma, I'm not going to discuss this in detail, because anyhow in your general oncology classes this would be discussed. What I've already told you, if you can remember, that the highest amount of mutations per megabase pair of DNA is found in melanoma. Okay, and all of these mutations ultimately they turn up into the two most common pathways, which are the MAP kinase pathway and phosphoinositol 3 or AKT pathway. Okay, only these two pathways, mostly in most of the tumors only these two pathways will come. Okay, but in case of malignant melanoma, these pathways have been studied elaborately. Okay, and it is sufficient for you to just remember that almost always, whatever be the treatment modality, ultimately they will be treatment modality based on chemotherapy drugs or immunotherapy drugs, or okay, any kind of those conservative management drugs, they will be ultimately directed towards one of the two pathways. So that forms the importance of this slide. Okay, coming to this UV radiation, quite a few times questions have been asked regarding this ultraviolet radiation. You see, ultraviolet, you have, you know that ultraviolet, the range of ultraviolet will be before the visible range. Okay, this will be before the visible range. So the ultraviolet will be well ahead, well before the blue or the purple range. So the wavelength of the ultraviolet rays would be less than that of 400 nanometers. Okay, so if you see this diagram, it would be evident that this ultraviolet is between 200 nanometers to 400 nanometers. And to be more specific, this would be for ultraviolet A. Okay, this would be for B, and this would be for C. So the wavelength goes in a reverse order. The ultraviolet A will have a longer wavelength, and ultraviolet C will have a very short wavelength. And that is how ultraviolet C would be filtered from the ozone layer. Most of the ultraviolet C gets filtered from the ozone layer, and almost a negligible amount comes onto the surface of Earth. So that is the reason why ultraviolet C is not usually contemplated for the skin malignancies. It is mainly ultraviolet A and ultraviolet B. Ultraviolet A has got a longer wavelength. It penetrates deeply into the skin and it has a major role in aging and wrinkling. Okay, but however, it is the predominant wavelength in tanning bed. So this is what people ask a lot of times. What is that ultraviolet which is causing skin cancers because of people getting bathed in the tanning beds? Okay, in the tanning beds, it is the ultraviolet A which is the major cause. Okay, but sometimes while getting tanned, most of the people, they undergo superficial burns. Okay, superficial burns only because of tanning. Okay, if that is the case, then the ultraviolet B is usually the culprit then. So ultraviolet B, which has got a lesser wavelength than the ultraviolet A, this damages the skin much more superficially. It cannot penetrate much more deeper, so the superficial skin gets burnt off. So these skin burns, which are a risk factor for your production of melanoma, are mainly because of ultraviolet B. Okay, so I think this is sufficient regarding few questions that you have to remember regarding your ultraviolet radiation with respect to malignant melanoma. Okay, you see, malignant melanoma most frequently they arise de novo. That is to say, they arise by themselves. There will not be any precursor lesion, but yet 40% of malignant melanoma may have precursor lesions. And the most common precursor lesions, I have already told you, these are the benign nevi. Okay, so these benign nevi are your like dysplastic nevi, your congenital nevi, and your Spitz nevi. Okay, dysplastic nevi or a common nevi, I've already told you, if they are more than 15 number or more than 2 millimeters in size, they are of a higher risk. At the same time, congenital nevi, which are the pigmented giant nevi, the size of which is more than, let us say, 20 centimeters, these are at risk of forming malignant melanoma. Okay, the other phenotypes associated with this congenital nevi are your nevus sebaceous and woolly hair nevi. Okay, the third most important precursor lesion is a Spitz nevi. Okay, nevi with mild dysplasia, they are very difficult to diagnose. Okay, nevi with mild dysplasia, they are very difficult to diagnose. That is to say, you have seen some pigmented lesion and you have suspected that this could be a melanoma, and ultimately you have taken a biopsy and they have given it as mild dysplasia. Okay, so and that too, it is very difficult to comment upon that there is a mild dysplasia in this pigmented lesion. But yet, don't get alarmed. You don't require to excise the complete specimen again. Okay, the complete lesion again to get into a negative margin. Let us say the pathologist has given a report of mild dysplasia. It is okay. You need not go back and re-resect the complete lesion again, or you need not get into a negative margin. Okay, so mild dysplasia is accepted in case of malignant melanoma until or unless there is no frank melanoma seen in the specimen. Okay, all the melanomas initially proliferate in the basal layer. Okay, this anyhow I think you know. Malignant melanomas mainly they proliferate in the basal layer. Coming to the subtypes of melanoma, you see there are almost 6 subtypes of melanoma that you have to remember. Out of them, the most important is the most common variety, which is the superficial spreading. The superficial spreading type of malignant melanoma is the most common type, and it has got something called your pagetoid spread. What is pagetoid spread? It is nothing but a horizontal spread. You understand what is pagetoid because you see you have something called Paget's disease, etc., wherein you know that the cells they form like a sheet, they go along the surface, right? So this superficial spreading, as you already know that melanoma has got two growth phases. One is a horizontal growth phase, horizontal growth phase. Okay, and the second is your vertical growth phase. Okay, vertical growth phase. Okay, so this superficial spreading is the one which has got mainly a horizontal growth phase alone. Okay, it has got a horizontal growth phase alone. So this is called what is called a vegetoid spread, and it is most commonly seen in your trunk and extremities. The second important type of malignant melanoma is a nodular variety. The important point that you have to remember is that this nodular variety is the one which has got the worst prognosis. Okay, this has got the worst prognosis, and they do not always conform to this ABCD criteria. I'll tell you what is ABCD criteria in some time. You see, anyhow, you also know about this ABCD criteria: A for asymmetry, B for your border, C for color, D for diameter, okay, E for elevation. You remember, right? So this nodular melanoma is the one which does not always conform to this ABCD criteria. Okay, there is a very high rate of amelanotic lesions in case of nodular melanoma. This is the one which you have to remember. So the nodular melanoma is that kind or that subtype of melanoma which has got high rates of amelanotic lesions. So the lesions can be white. Okay. The third subtype of malignant melanoma is your acral lentiginous melanoma. You see, acral lentiginous melanoma is a less common variety, but however, it is the most common type of melanoma in black patients or the black population. Okay, histologically, it is much similar to the melanomas arising from the mucous membrane. So these three are the most important initial subtypes of malignant melanoma, followed by the other three subtypes, which are your lentiginous melanoma, lentigo maligna, and desmoplastic melanoma. You see, this lentigo maligna is something like in situ lesion. It is also called Hutchinson's freckle, and it has a propensity to develop in the face. Okay, as you can see in this patient. Okay, as you can see in this patient, this malignant melanoma subtype lentigo maligna, which is mainly an in situ malignant melanoma, it has a propensity to form in face. Okay, the most important the subtype that you have to remember is another subtype called the desmoplastic malignant melanoma. And the important point that you have to remember here is the neurotropism. So this desmoplastic malignant melanoma variety has got neurotropism. So it has much more predilection to invade the nerves. However, it has got a very low risk of lymph node involvement. Okay. So coming to the clinical features, as I've already told you, the initial evaluation of malignant melanoma, the primary physician whenever sees the lesion and if the patient gives any of these following histories, then he has to suspect malignant melanoma. You see, these are the A, B, C, D, E. So A for asymmetry, B for border irregularity, C for color change, D for diameter more than 6 millimeters. This is what you have to remember. E for evolution. Okay, E for evolution, that is to say, if the patient remembers how the lesion has evolved, let us say from a very small mustard seed size lesion slowly increasing in size. Okay, so and later on changing its color, later on becoming the borders becoming irregular. So this is the evolution of that lesion. So that is how you can suspect a lesion to be a malignant melanoma. If, let us say, if the patient has got a multiple moles on his body, okay, or if the patient has got something called a multiple mole syndrome, in that case you have to suspect melanoma in the most ugly looking lesion. So this is called what is an ugly duckling sign, wherein you see the most ugly looking pigmented lesion should be suspected of being a malignant melanoma. Okay. So going ahead with the evaluation of this malignant melanoma, after you make a clinical diagnosis of malignant melanoma, the second step would be to take a biopsy, right? And the important point that you have to remember is that excisional biopsy is the most appropriate biopsy. So the most appropriate biopsy for malignant melanoma is an excisional biopsy, and this excision should be done with a 1 to 2 millimeters of margin. Okay. For a large lesion which is more than 2 centimeters, and that too if it is present near the face or a part of body wherein you cannot give a much more margin, let us say, or which will cause deformity or something like that, you can go ahead with the incisional biopsy. So it is accepted for a large lesion which is more than 2 centimeters, you can take an incisional biopsy. Okay. The third in order would be your punch biopsy, which is least advised. Okay, punch biopsies are least advised because you will have problems regarding the thickness, commenting upon the thickness of the lesion. You cannot comment on the thickness of the lesion because you have taken a punch, and sometimes in the punch you might not get into the depth of the lesion. Okay, why is this important? Why is this that the thickness is important? Okay, because this thickness, based upon this thickness, you have the T category of the malignant melanoma. Okay, so another important point that you have to remember is how do you measure this thickness in malignant melanoma? You see, thickness in case of malignant melanoma is measured from your granular layer. This is what you have to remember, because in case of squamous cell carcinoma, which is mucosal, okay, so mucosal squamous cell carcinoma, you measure the depth or depth of invasion, okay, is measured from the basement membrane. It is measured from the basement membrane, whereas squamous cell carcinoma of skin or cutaneous, okay, same way it is the malignant melanoma cutaneous. All these cutaneous lesions, the thickness or the depth of invasion, or you can also call it as depth of invasion, this is measured from the granular layer. You draw what is called a plumb line. Okay, this is this vertical line here. This vertical line is called the plumb line. Okay, when you take granular layer as the reference and then draw a plumb line, this is what you do in case of cutaneous malignancies. Whereas in mucosal malignancies, you draw this plumb line from the basement membrane. Okay, so this is regarding the biopsy part. Okay, then going ahead with the further investigation or further evaluation, once you have got a biopsy and biopsy says that it is malignant melanoma, then you have to stage the disease, and clinical staging is the best staging for malignant melanoma. However, if you find that the depth of the invasion is more, that is, it is a thicker melanoma, then you are justified in taking a PET CT or PET MRI. So this is usually indicated in advanced stages, let us say stage 3 or 4, that is to say if you're able to find some nodes or something like that. Okay, in that case you are justified in taking a PET CT or an MRI as a staging workup for malignant melanoma, as has been endorsed by NCCN. Okay, this has been endorsed by NCCN. Okay. So going ahead with a few more points regarding the prognostic factors for malignant melanoma. You see the tumor thickness, which is the Breslow's thickness, presence or absence of ulceration. Okay, sex of the patient, male sex, usually they will have poor prognosis. Location of the disease, you see the extremity will have a poor prognosis rather than your head and neck. Okay, and your mitotic rate more than 6 per millimeter square is a poor prognostic factor. Okay, you see, so these are the prognostic factors that you have to remember, and few more points that you have to remember is regarding the tumor regression. This is important because you see, one major way a malignant melanoma can present is like a secondary node without a primary. Okay, you see, sometimes you will have a cervical node or an axillary node or an inguinal node wherein the FNAC shows that there is a malignant melanomatous deposit. But however, when you search for the primary lesion in the draining part of that part of the skin, you won't be able to see the melanoma or any pigmented lesion. You know why this occurs? Because until now, among all the tumors that we have studied, malignant melanoma is one kind of a tumor which has got a spontaneous regression mainly because of a good immunological response to the body's immunity. You see, if the body's immunity is to such an extent that it can identify this tumor in the skin, and it can target it and remove this tumor completely from the body, the tumor regresses. Okay, the tumor regresses, or let us say with the treatment, the tumor regresses. Whatever it is, the tumor regresses. So once the tumor regresses, you won't be able to see the lesion there, but however the lymph nodes will be having the disease. Okay, in those cases, what you have to remember is, though there is a tumor regression, this does not affect the metastasis or survival. This does not affect the metastasis or survival. Another important point that you have to remember is that regarding ulceration. You see, ulceration and increased mitotic rates, these are considered some poor prognostic factors, and they are linked to the risk of nodal metastasis. Okay, so though they are also a poor prognostic factor by themselves, they also add upon because they are linked to the risk of nodal metastasis also. Okay, so this slide is regarding the thickness of the malignant melanoma. The most common way that we tell is regarding the Breslow's thickness. Previously, they used to tell regarding Clark's. Okay, Clark's 1, 2, 3, 4, 5, wherein Clark's 1 will be restricted itself to epidermis. Okay, Clark's 2 will be spanning the epidermis and it will be entering the papillary dermis. Clark's 3, level 3, would be spanning the papillary dermis and reaching up to reticular dermis. Okay, whereas Clark's 4 will be going into the reticular dermis. Okay, and Clark's 5 will be spanning from the epidermis into the papillary dermis into the reticular dermis. Okay, completely through the reticular dermis, and it will be invading the subcutaneous tissue. Okay, so this was the Clark's level of malignant melanoma. This was used previously. But as of now, the uniformity among the depth of invasion has come, and this has been given by Breslow. This has been given by Breslow, and you have Breslow's thickness of 1, 2, 3, 4 again. Okay. And this thickness and this Breslow's thickness again, these are taken from the granular layer. You draw a plumb line from the granular layer and you measure the thickness as 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter, or 5 millimeter. Okay, based upon this only you have the T category of the malignant melanoma. So going ahead with the T category of malignant melanoma. Okay, you see T1, T2, T3, T4, these are based upon the Breslow thickness of 1 millimeter, 1 to 2 millimeter, 2 to 4 millimeter, and more than 4 millimeter. This baseline T category you have to remember. So T1 less than 1 millimeter thick, T2 1 to 2 millimeter thick, T3 2 to 4 millimeter thick, and T4 is more than 4 millimeter thick. This is the thickness and this is not the size. So here in malignant melanoma, size is not the issue. It is the thickness which is the issue. Okay. Further, these lesions T1, T2, T3, T4 have been divided into two, which are A and B. A is usually without ulceration, okay, and B is with ulceration, but still. So you have T1AB, T2AB, T3AB, and T4A and B. For almost all practical purposes, A means without ulceration and B means with ulceration. But there is an exception, and this exception is T1. Okay, in T1, A and B, they don't completely constitute as without ulceration or with ulceration. But however, this is regarding the division of the depth itself. You see, T1A is less than 8 millimeters deep. T1A is less than 8 millimeters deep. Okay, and without ulceration. T1A is less than 8 millimeters deep and without ulceration. Okay, T1B is 8 millimeters to 0.8 millimeters to 1 millimeter. 0.8 millimeters to 1 millimeter with or without ulceration. with or without ulceration. At the same time, T1B also includes a lesion which is less than 0.8 millimeters and with ulceration. Okay, so I think I need to repeat again. You see, T1A and B are not only regarding with ulceration or without ulceration. You see, T1A is a lesion which is less than 8 millimeters without ulceration. T1B is a lesion 0.8 millimeters to 1 millimeter with or without ulceration, and also a lesion which is less than 0.8 millimeters with ulceration. Okay, so this brings us to a very peculiar point wherein you see there is a lesion without ulceration in T1B in B category. If you see T2B or T3B or T4B, every B will contain ulceration only. Okay, even T1B contains an ulceration which is less than 8 millimeters thick but ulcerated. Similarly, you have 0.8 millimeters to 1 millimeter with ulceration. Okay, at the same time, this 0.8 millimeters to 1 millimeter thick without ulceration is also included in T1B. This is what you have to remember. Okay, and this is the reason for this point that I am going to highlight. You see, T1B is, for your common understanding, as the T category increases, okay, the nodal category also increases. Let us say T1 will have T2 will have much more higher nodal positivity than T1, right? That is what is common understanding. Similarly, T3 will have a much higher nodal category than T2. That is a common understanding. But however, T1B is one category wherein this has got a slightly worse survival than T1A, but not necessarily with higher risk of nodal metastasis or sentinel node metastasis. This is because you have a subset of patients without ulceration in T1B. So you have a separate subset of patients without ulceration in T1B. So, and we have learned already that ulceration is associated with lymph node metastasis. When you don't have ulceration, then you will not have the risk of getting metastasis also, or lymph node metastasis also. So this is the take-home message from this slide. The other T categories are your TX, okay, wherein the primary tumor thickness cannot be assessed, okay, because you have taken a curettage or something. Okay, and T0, that means there is no evidence of primary tumor at all. This is like an unknown primary. This is something like an unknown primary. And TIS, which is malignant melanoma in C2. Okay, this is malignant melanoma in C2. Coming to the N category of malignant melanoma. Okay, this is also simple to understand. Don't get terrified of looking upon this slide. You see, there is a very easy way to understand and remember this N category of malignant melanoma. You see, A is always a occult node. You will have N1, N2, and N3. Okay, that is basic. You will have in N1 ABC, in N2 ABC, and in N3 also ABC. A is basically an occult node, or a node which is identified by sentinel lymph node biopsy. Okay, B is clinical node, that means you have seen it clinically, and C is a lesion which is a in transit lesion. You can have a node, you cannot have a node, but ultimately you will have a satellite lesion or a in transit lesion, once it comes to C. Okay, so how do you define them, these ABCs, in N1, N2, and N3? You see, in N1A will be your occult node, but only one. Okay, N2A will be 2 to 3 nodes occult. Okay, and N3 you'll have 4 or more nodes which are occult. Okay, and these are usually, how do you know they are occult? You have not seen them clinically, but once you have done a sentinel node biopsy, you have found them. If you have found one node in sentinel node, it is N1A. If you have found 2 to 3 nodes, it is positive. Okay, 2 to 3 nodes positive, then it is N2 disease. If you have found 4 or more sentinel nodes positive, it is N3A. Okay, on the other hand, if clinically detected, single node clinically detected, N1B. 2 or 3 nodes clinically detected, N2B. 4 or more clinically detected nodes, N3B. Okay, or if you have matted nodes also, it is N3B. Okay, what the difference is with C category: N1C, N2C, and N3C. N1C is a category wherein you have no regional nodes either by occult or by clinically detected nodes. Okay, there will be no nodes, but however, you will only have a transit lesion or a satellite lesion. You will have only a in-transit lesion or a satellite lesion. Okay, in-transit lesion is a lesion which is within 2 centimeters, and a satellite lesion is a one which is beyond 2 centimeters of the index primary lesion. Okay, in transit is, sorry, satellite is less than 2 centimeters radius, and in transit is more than 2 centimeters radius. Okay, let us say if you have, a single melanoma within 2 centimeters of range, if there are any other lesions, they are satellite lesions. Okay, beyond 2 centimeter lesion, so 2 centimeters range, if you have any other lesion of the same malignant melanoma, they are called, let us say, they are the tumor deposits of the primary malignant melanoma in the skin beyond 2 centimeters range. They are called the in-transit lesions. Okay, so if you have these in-transit lesions or the satellite lesions in the absence of a lymph node, it is N1C. N2C is basically N1C, N1A or N1B plus these in-transit or satellite lesions. N3C will be N2A or N2B plus your in-transit or satellite lesions. So this is how you can remember the N category of malignant melanoma. So in N category you will have NX, wherein regional nodes cannot be assessed. Okay, because already a dissection of that lymph nodal basin has been done previously. Okay, or second category would be N0, where no regional metastasis has been detected. Others will be your N1, N2, N3. In each of them you have A, B, C. A is for occult, B is for clinical, and C is for your in-transit or satellite lesions. Okay, coming to the M category. Okay, you see, the M category is important for you to remember, because in M category also you have M1, A, B, C, and D. And in each of the metastatic categories, again, you have 0 and 1. You see, 0 is the are those patients wherein LDH is not elevated, and 1 are those categories wherein LDH is elevated. So now this brings us to another juncture wherein you understand that malignant melanoma is such a kind of tumor or such a kind of cancer wherein non anatomical markers like your serum markers have been taken into account for the stage grouping or metastatic categorization of the patient. Okay, so similarly you have another tumor also, like your germ cell tumors, wherein the serum markers have been included into the staging of the tumor. Okay, so melanoma is another such tumor wherein, apart from your anatomical markers like your T size, nodal size, and metastatic you also have a non-anatomical markers like your serum markers included into the staging. So this is how, if you have LDH elevated, you are categorized as 1. If you don't have LDH elevated, you are categorized as 0. So what are these M1A, B, and C, and D? You see, M1A is a metastasis, as a distant metastasis to skin soft tissues, including the muscle or some non-regional lymph nodes. M1B is metastasis to the lung, with or without M1A. M1C would be a metastasis to all visceral sites other than CNS. Okay, and M1D is CNS metastasis, and these can be with or without your M1A, M1B, or M1C. Okay, so this is regarding the M category or metastatic category of malignant melanoma. Going ahead with the stage grouping now. Okay, Don't get confused with the stage grouping also. You need not remember the stage grouping, because you know why? Because the treatment part usually does not depend upon the stage. That is to say, you have diagnosed a malignant melanoma from a biopsy. You have tried to know the T category, you have tried to know the N category, okay, you have tried to know the metastatic category, and you have brought about the staging of this malignant melanoma. Still, you will not treat the patient based upon the stage. You will treat the patient based upon the thickness, okay, and based upon the number of nodes involved. So basically, that is sufficient for you to treat the patient of malignant melanoma. So that brings us to this juncture wherein I'll just give few tips to understand this staging. You see, whatever be the depth of invasion, if there are no nodes involved, okay, either clinically or with sentinel node biopsy, you have not detected any lymph nodes, all of them are your early stage disease only. Okay, so they will be basically stage 0, stage 1, and stage 2. 1A or B, 2A, B or C. Once you have got nodes, it is stage 3. And once you have got metastasis, it is stage 4. That's all. I think this is sufficient for you to remember regarding the staging of malignant melanoma. Whenever you have nodes involved, either clinically or by an occult disease, okay, or in-transit lesions are present, that means it is stage 3. Other than that, everything is an early stage disease, which is stage 1 or stage 2. If you have metastasis, it is stage 4. Okay, so I think that is sufficient for you to remember regarding the staging of malignant melanoma. Okay, so having understood this whole things, that is regarding some basics regarding your skin, okay, then etiology regarding your malignant melanoma, okay, types of malignant melanoma, okay, and then how to evaluate a patient of malignant melanoma. Ultimately, this brings us to the management of malignant melanoma. How do you manage a case of malignant melanoma? Okay, so as I've already told you, you need not remember the staging of the disease. You see the first sentence of this slide: treatment of localized melanoma. So the ultimate understanding, the ultimate what do you say, the information that you gather upon evaluating of my patient of malignant melanoma is to see whether it is a localized malignant melanoma or non-localized. That is to say, it has gone into the regional lymph nodal stations or to metastasis. So for a localized melanoma, the treatment is wide local excision with sentinel node biopsy. Okay, that means to say, clinically you have not found any nodes and the lesion appears only in the restricted only to the skin, and you have found it in your biopsy. So this makes a localized malignant melanoma, and the treatment would be wide local excision with a sentinel node biopsy. Why wide local excision? Because you have taken just a biopsy with just some 1 to 2 millimeters, so you will have a scar. For this scar, you have to do a wide local excision with a sentinel node biopsy. Now the question arises, how will you do a sentinel node biopsy? You have already removed the primary, right? Even though you have removed the primary, you try to give the dye, or you try to do the sentinel node biopsy procedure by injecting the thing, either the dye or the radiocolloid, whatever it is, intradermally in and around the scar, and do the procedure. Okay, so this is the treatment for localized malignant melanoma. But still there is an exception for this. Okay, the exception for this sentinel node biopsy is a patient wherein you have found malignant melanoma in situ, or a lesion which is less than 8 millimeters thick, that is T1A, okay, and low mitotic rate. That means, and also not ulcerated. Let us say it is an unulcerated T1A lesion. T1A lesion is basically an unulcerated lesion which is less than 0.8 millimeters thick, and it has got a low mitotic rate. Then only you can avoid doing sentinel node biopsy, but still you have to do a wide local excision. Okay. With a high mitotic rate, that is more than 6 per millimeter square, the same T1A lesion, you need to do sentinel node biopsy. Okay. Coming to this margins for this wide local excision, you see, based upon the depth, your margin changes. Okay. If you find that it's an in situ lesion, then a margin of 0.5 to 1 centimeter is sufficient. For less than 1 millimeter, 1 centimeter. For 1 to 2 millimeters, 1 to 2 centimeters. Anything beyond 2 millimeters of thickness, you need to give 2 centimeters of margin. Okay, and this understanding of thickness to the margin, this was brought about by various trials that I have enumerated here. You have something called the WHO trial and the French and Swedish trials. Okay, these were the two trials which have learned or which have given us the information regarding the margins that you have to take for thin and intermediate thickness melanoma. So what are these thin and intermediate thickness melanoma? You see, anything T1, T2 lesions and a few of the T3 lesions, they are considered, or let us say T1 lesions are your thin melanomas, T2 and T3 are your intermediate thickness melanomas, and T4 are your highly thick melanomas, okay, or very thick melanomas. Thin, intermediate, and thick. Thin is T1, intermediate is T2 and T3, and T4 is thick. Okay, so the WHO and the French or Swedish trials, they have given the margins for, they have given your recommendations for margins for thin and intermediate thickness melanoma. British intergroup trial, this has given the recommendation for thick melanomas. Okay, this is what you have to remember. Okay, what is this importance? Since these patients of localized melanoma, they don't have any lymph node metastasis as of now, for your understanding. Okay, as the thickness increases, so as the T stage increases, they will require an adjuvant interferon therapy. And another important point that you have to remember here is in malignant melanoma is regarding the sentinel nodes. Whenever you do a sentinel node biopsy in case of malignant melanoma, they should not be sent without frozen, without formalin fixation. Okay, so these sentinel nodes should be formalin fixed. Okay, for your common understanding, whenever you do frozen section, what you do is you ring up to your pathologist and you say that I have sent the specimen. You just see, you put it in the that machine, okay, frozen machine. Then and they'll prepare sections of that frozen section, and they will see the tissue under the microscope within your 15 to 20 minutes of your 15 to 20 minutes of your procedure, and tissue has been sent. They will prepare the frozen, and then they will give you the report. Okay, but later on they will fix the tissue back in formalin, and then they'll give a formal report later on. Okay, that is how our normal frozen sections are being done. However, in case of malignant melanoma, these sentinel nodes, even though you say you are sending for sentinel node biopsy, you don't send them for frozen section. You fix them in formalin and then get a formal report only. Don't send them for frozen section. Most of the sentinel nodes done elsewhere, let us say for endometrium or for breast, etc., sentinel nodes are sent for frozen. Okay, they are sent for frozen. They will see whether they are positive or not. If positive, they will go ahead with the completion of axillary dissection or completion of the pelvic dissection. That is how they will do. But in case of malignant melanoma, sentinel nodes, they are not sent for frozen. They should be formalin fixed and get the report. Okay, so just going ahead with further discussion regarding this sentinel node in case of malignant melanoma, you see two dyes are used here. One is technetium-99 sulfur colloid, which is a radio dye, okay, radio colloid, and the second is your isosulfan blue. Isosulfan blue does not persist for prolonged periods within the tissues. Okay. So initially they used to use this isosulfan blue, but however now they have combined along with your technetium-99 sulfur colloid. So for all practical purposes, as of now, we are using these dual dyes. You use both technetium-99 sulfur colloid along with isosulfan blue to do this procedure of sentinel node biopsy in case of malignant melanoma. And how do you do it? You inject these two drugs within the dermis. So this is important. They are injected in the dermis. Okay. Sentinel node is defined as any lymph node which is most radioactive, as you can understand. Okay, since you are giving a radiocolloid, any node which has got the highest amount of radioactivity, or those who have been taking the radioactivity, will be considered a sentinel node. At the same time, since you have also used a blue dye, okay, if those blue dyes also have taken the radioactive substance, and yet the radioactivity is less than 10% of the highest radioactive node, you can ignore them. Only those blue nodes whose radioactivity is 10% or higher than the most radioactive node, they should also be considered as a sentinel node. Okay, so this you have to understand. Another few more points that you have to understand is that only 15 to 20% of the patients with positive sentinel nodes have additional micrometastasis in non-sentinel nodes after your completion lymph node dissection. Let us say you have got some sentinel nodes, and as for your institution protocol, you have not completed the lymph node dissection. So out of them, 15 to 20% of the patients can have metastasis in the other non-sentinel lymph nodes. I will tell you the importance of this in the next slides, a few coming slides. Okay. So if no sentinel node is identified after injection, initial injection, few of the times it so happens that you have proceeded with your dyes, injections, everything has been given, but you are unable to identify any sentinel node. What usually people do, and what is the common understanding and common teaching, is to do a complete lymph node dissection of the draining area. Okay, let us say for an axillary dissection, or let us say for a pelvic node in case of endometrium. If you are unable to find any axillary sentinel node or a pelvic sentinel node, you go ahead and you do the completion lymph node dissection, right? But however, in case of malignant melanoma, if no sentinel node is identified after your initial injection, you always have a choice of repeating the injection and a proper technique again. Okay, this you have got in malignant melanoma. Okay, another important point that you have to remember is that this combination of your blue dye and radiocolloid, this increases the identification rate to 99%. Why? Because previously, whenever they used to use only the blue dye, the identification rate used to be 87%. So these two percentages you have to remember. So combination of blue dye and radiocolloid dye increases the identification rate by 99%. Okay, so not only this, you see, this sentinel node biopsy using this radiocolloid has avoided missing out any atypical nodes. Okay, so another reason why only blue dye is not used and why a combination is used is because whenever you use a blue dye only, you are liable to miss the atypical nodal basins. And what are these atypical nodal basins? These are the triangular intermuscular spaces on the back, epitrochlear nodes, your popliteal nodes, and few of the subcutaneous in-transit nodes. So these are the atypical nodal basins that you are likely to miss if you use only a blue dye. Okay. So having understood this, having understood that for a localized melanoma, you do a wide local excision followed by a sentinel node biopsy using your dual dye technique, ultimately, what will you do if you get a positive sentinel node biopsy? Okay, then you have two options. Either you can do a completion lymph node dissection or you can just observe. Okay, and both of them are equally effective. Okay, you see, based upon a lot of studies, okay, they have come to a conclusion that either a completion lymph node dissection or an observation are equally effective in the management of a positive sentinel node biopsy in case of malignant melanoma. However, patients with high risk of non-sentinel nodes. You see, I said that non-sentinel node, the risk of involvement of non-sentinel node will be around 15 to 20%, right? Few patients will have even higher risk than that of 15 to 20%. And those patients are those who are having your extracapsular extension, multiple positive sentinel nodes, that is more than 4 in number, let us say, okay, or a large tumor burden in nodes. Let us say the size of the node itself is such large that it is jam packed with these malignant melanoma cells, melanomatous cells. In these cases, the completion lymph node dissection is preferred. Okay, otherwise in most of the cases, observation is a well accepted alternative. Okay, whenever a patient of you has found to be a positive sentinel node biopsy, then you see whether he is having an extracapsular extension or he is having a multiple sentinel nodes, more than 4, or a large tumor burden in the nodes. If these are present, then it is better to go ahead with a completion lymph node dissection rather than observation. And this whole thing is based upon your German DCOG study and MSLT 1 and 2 trials. Okay, and the management, however, of a palpable lymph node is your therapeutic lymph node dissection. And then it is not a localized melanoma, though it is a regionalized melanoma. There also you have the same treatment. You have wide local excision with a therapeutic lymph node dissection. This is what you do for a regional metastasis to lymph nodes for a malignant melanoma. Okay, that is to say a stage 3 disease. Okay. So let us just learn few more points regarding these MSLT trials, because these have been asked previously in quite few of the exams. Okay, MSLT stands for multi-center selective lymphadenectomy trial. Okay, MSLT, and you have two MSLTs, MSLT1 and MSLT2 trial. MSLT1 is the one which compared between observation versus sentinel node biopsy in case of intermediate and thick melanomas with N0. If you have a patient with intermediate and thick melanoma and it is clinically N0, okay, after doing wide local excision in MSLT1 trial, they have compared between observation and sentinel node biopsy. And they have found, and all the patients who have been found positive with sentinel node biopsy underwent completion lymph node dissection in that study. What they have found is that there is no difference in 10-year melanoma specific survival. However, there is an improved 10-year disease-free survival in sentinel lymph node biopsy group. Okay, since they have undergone this completion lymph node dissection. So this was their conclusion. However, in MSLT2, they have taken sentinel node positive patients directly. They have taken sentinel node positive patients and they have compared observation to that of completion lymph node dissection. Here they have found that there is again no difference in disease specific survival. Okay, here in MSLT1 they have found that there is no difference in 10-year melanoma specific survival. Here also they have found that there is no difference in disease specific survival in both groups. However, they have added saying that it is safe and reasonable. It is safe and reasonable to avoid completion lymph node dissection in vast majority of the patients with positive sentinel nodes. Okay, so this observation of patients having still the positive sentinel nodes is based upon this MSLT2 basically, and also the German DCOG study that I have already mentioned. Okay, however, keep in your mind completion lymph node will be required for those patients with high risk features like your extranodal extension, okay, or your increased number of nodes or high nodal burden, or a node with a high burden of disease. Okay, For those patients, completion lymph node dissection is indicated. Okay, having done your surgical part, now you have to assess whether your patient requires an adjuvant radiotherapy. Okay, so the indications of adjuvant radiotherapy. You see, if one or more positive parotid nodes are there, or two or more positive cervical or axillary nodes are there, three or more positive inguinal nodes are there, then you need to give adjuvant RT. You can remember this as 1, 2, and 3. 1 in case of parotid, 1P, 2 in case of cervical or axillary node, and 3 in case of inguinal node. At the same time, if you have an inguinofemoral node which is more than 4 centimeter in size, okay, or you have a cervical node which is more than or equal to 3 centimeter in size, you have to give an adjuvant RT. Okay, presence of extranodal extension is an indication for adjuvant RT, and desmoplastic melanoma, irrespective of its size or lymph node involvement, is an indication for adjuvant RT. So these are the various indications of adjuvant RT in case of malignant melanoma that you have to remember. Okay, so going ahead with our discussion further regarding your satellite lesions and in-transit lesions. You see, I've already told you the satellite lesion is a one which occurs within the 2 centimeter range. Okay, as you can see in this image, you see you have a malignant melanoma here, and you have to draw a range of 2 centimeters. Any secondary lesion within these 2 centimeters is called a satellite lesion, whereas any other lesion beyond these 2 centimeters and mainly within the lymphatic drainage pathway, these are called the in-transit lesions. Okay, most of the satellite tumors and in-transit metastasis, they are grouped as, I told you, C category of nodes, right? You also have something called microsatellite tumors, and these are seen only in microscope. Microscope. Okay. So what's the treatment if you have these satellite lesions or in-transit lesions? Basically, it makes them stage 3 disease, right? So the treatment is resection again. And if you have nodes with them, with the patient, you do a therapeutic lymph node dissection. If you don't have lymph nodes, then you have to go for a sentinel node biopsy again. Okay. For those patients who are not amenable for resection, let us say, if these satellite lesions or in-transit lesions are to such an extent that they are involving whole of the limb or a very wide range such that you cannot do a wide excision, that means if you go for a wide excision, you will be ripping apart a lot of the tissues, and ultimately you will be left out with a very large raw area which you cannot reconstruct. If such is the thing, then for those patients who are not amenable for resection, you can use intralesional BCG, interleukin-2, interferon therapy, and talimogen herpavec. I will tell you later what is this talimogen herpavec. Okay, just remember it is a something like a vaccine. Okay, something like a vaccine which you can give intralesionally in the melanomatous satellite lesion or an in-transit lesion. For still extensive and recurrent lesions, what you can do is hyperthermic isolated limb perfusion, which is a HILP, which is using melphalan. You also have isolated lymph infusion. Okay, there is no much difference between hyperthermic isolated limb perfusion and isolated limb infusion. The only difference being that you will not have oxygenation and you will not have hyperthermia in case of isolated limb infusion. Okay. So this is regarding the management of the satellite lesions or the in-transit lesions in case of malignant melanoma. Okay. Then how do you treat a metastatic malignant melanoma? You see, the treatment of metastatic malignant melanoma, there are a few drugs that you have to remember, and most commonly asked drugs are these 4. Okay, pembrolizumab, which is a PD-1 inhibitor, ipilimumab, which is anti-CTLA4 antibody, vemurafenib, which is BRAF inhibitor, and trametinib, which is MEK inhibitor. It is sufficient for you to, if you just remember these names, the mechanism of action, etc., would already have been discussed in your general oncology, I suppose. Okay, so these few drugs which are most commonly used as of now, and out of them pembrolizumab is the one which is in common usage as of now for metastatic malignant melanoma. Okay, the others are like your ipilimumab, vemurafenib, and trametinib. Another important thing that you have to remember is a Darmouth regime. Okay, this was a question which has been asked quite a few times in your previous exams. As of now, nobody uses a chemotherapy, first-line chemotherapy as a treatment of choice for malignant melanoma. Since all these new drugs have come, okay, all these new targeted drugs have come, but still few institutes, they still use chemotherapy drugs. Whenever chemotherapy was previously being used, they used something called a Darmouth regime. So what is this Darmouth regime? So this Darmouth regime is a combination of cisplatin, carmustine, dacarbazine, and tamoxifen. In them also, you try to understand that there is something tamoxifen which is not at all a chemotherapy drug, which is a hormonal drug. Okay, so you have cisplatin, you have carmustine, you have dacarbazine along with tamoxifen, So 3 plus 1, 4. A total of 4 drugs are used in Darmouth regime. Okay. So coming to what is the role of surgery in metastatic disease. So now you have understood how to treat a localized disease. You have understood how to treat a regional disease, that is the one having lymph nodes. You know how to treat a in-transit lesion or a satellite lesion. You also understood how to treat a metastatic lesion using your drugs. At the same time, you also have few patients who might require surgery even though they are metastatic, right? In case of malignant melanoma, the role of surgery in such metastatic disease is very much limited, and this limitation is to these subgroup of patients. You see, if you have anemia due to occult bleeding from GIT metastasis, okay, or you have a metastasis causing bowel obstruction, or you have cutaneous metastasis with pain and ulceration, or a lymph node with neurological symptom, or you have symptomatic brain metastasis, or of life-threatening bleeding from metastasis, and these are the subgroup of patients wherein you have a justified role of surgery in metastasis. Okay. So few more points that you have to remember in case of malignant melanoma, which are of your exam point of view, they're important. These are like your ocular melanoma, wherein the metastasis is exclusively to liver. Okay, sentinel node biopsy can be done for a second primary lesion also. Okay, so that is the reason you see observation. Even though you have a positive sentinel node biopsy, still you can keep the patient on observation. That is to say, if later on the patient gets another second primary, still you can do the same treatment, which is wide local excision with sentinel node biopsy. Okay. Then you have something called the IHC markers for melanoma. You see, S100, HMB45, Melan A. So these are the IHC markers for melanoma. Okay, and I have told you something regarding your talimogene herpavec. You see, talimogene herpavec is a genetically engineered oncolytic herpes virus with granulocyte monocyte colony stimulating factor. So basically, these are the oncolytic herpes virus which have been genetically engineered, which go and kill the melanomatous cells. Okay. UVA forms cyclobutane pyrimidine dimers in DNA for melanocytes. So this forms the basis of oncogenesis for melanoma. So this was also previously asked, a question which was previously asked. So UVA is related to the formation of melanoma. How? It is by the formation of cyclobutane pyrimidine. Okay. Few more points that you have to remember is that patients with unknown primary melanoma who present as lymph nodal metastasis, okay, they have better overall survival as compared to those with known primary lesions. Okay, this I've already told you why, because this is related to the strong immune response of the patient. So these patients, since they have a strong immune response, the primary melanoma has regressed and only lymph node alone is left out. So that is why they have presented to you as an unknown primary with melanomatous lymph node metastasis. That is why they have better overall survival. Okay. In pregnancy with melanoma, the guidelines, they don't change. You treat the patient in the similar way, because there is very limited evidence to say that these radiocolloids are actually detrimental for the patient or they are teratogenic. We don't have much data saying that they are so. So that is why you go ahead with the similar kind of guidelines in the treatment of melanoma, even in a case of pregnancy. Okay. And they have found that there is no therapeutic benefit in early termination of this pregnancy. Okay. The most common site of mucosal melanoma in head and neck is oral cavity. Sorry. The most common site of mucosal melanoma is head and neck, and in head and neck, it is the oral cavity. Okay. So this completes your melanomatous skin tumors. So going ahead with our discussion regarding the other non-melanomatous skin tumors, let us start with your squamous and basal cell carcinoma. You see, the treatment aspect of both of them are almost the same. Okay, and both of them, they don't have any staging, AJCC staging. Okay, so that is to say the squamous cell carcinoma or the basal cell carcinoma, unlike your melanoma, they don't have any AJCC stage grouping. So that is one good point that you can be happy with. Okay, so going ahead with your squamous cell carcinoma, you see the most common etiological factors that are contributing to this squamous cell carcinoma are your actinic keratosis. Okay, ultraviolet radiation, as I've already told you, chronic exposure, that your cumulative exposure, okay, is a risk factor for formation of squamous cell carcinoma, because these chronic exposure and cumulative effect of this UV rays leads to P53 mutation. Okay. Organ transplantation, yes, you have 10-fold increased risk. This is because of immunosuppression again. Occupational exposure, same as of malignant melanoma, you have arsenic, you have hydrocarbons, organic hydrocarbons, and cigarette smoking. Previous burns is a risk factor for Marjolin's ulcer, and chronic inflammation, as in case of mucosal squamous cell carcinoma, is also a risk factor for squamous cell carcinoma cutaneous. Okay, PUVA therapy is a risk factor for squamous cell carcinoma. Okay, and heritable conditions like xeroderma pigmentosa, dystrophic epidermolysis bullosa, and occutaneous albinism. Okay, these are all the conditions with high risk of squamous cell carcinomas. And drugs, as I have told you, in malignant melanoma also, voriconazole and vemurafenib, they are associated with the formation of squamous cell carcinoma. Pathologically, keratin pearls, these are the pathognomonic of squamous cell carcinoma. Okay, here you can see these keratin pearls. These are nothing but the keratin which are formed by the denuded squamous cells, okay, layer by layer around a nidus, okay, thereby forming a pearl-like thing. So this can be seen under microscope, and a well differentiated or a moderately differentiated squamous cell carcinoma, let us say, they will have these keratin pearls. Okay, lymph nodal spread is mainly more common. Okay, in squamous cell carcinoma, the lymph nodal spread is more common than your basal cell carcinoma. Okay, 25 to 50% of acne keratosis, they regress spontaneously. I've told you one of the etiological factor, per se, the first etiological factor that I've told you regarding squamous cell carcinoma was acne keratosis. Okay, but however, 25 to 50% of these acne keratosis, they regress spontaneously. Okay, a word regarding this Ferguson-Smith syndrome. You see, this is one syndrome where you have multiple healing squamous cell carcinomas. Okay, this is an autosomal dominant disease, and this is related to the mutation in chromosome number 9. Okay, and here you have multiple self-healing squamous cell carcinomas. Going ahead with basal cell carcinoma, as I've already told you, this is the most common skin cancer, and the mutations attributed to this is regarding your hedgehog signaling pathway. Okay, And unlike your squamous cell carcinoma or your malignant melanoma, okay, there are no precursor lesions at all. There are no precursor lesions for basal cell carcinoma at all. Okay, inherited lesion conditions like nevoid basal cell carcinoma, Base-X syndrome, which is an X-linked dominant syndrome, xeroderma pigmentosa, and Rombo syndrome. These are few heritable conditions, okay, that you have to remember regarding the risk factors for basal cell carcinoma. Sun exposure, yes, it is a risk factor, and usually these basal cell carcinomas are very slow growing tumors, and they have something called stromal dependency. This is one important point that I have to stress upon: stromal dependency. You see, these basal cell carcinomas, they thrive upon the stroma. Okay, the stroma actually supports these basal cells. That is the reason they rarely metastasize. That is to say that if these basal cell carcinomatous cells, they leave their stroma and they try to metastasize and go somewhere else, let us say, okay, in that new place, in that new soil, they cannot survive because they're dependent on the stroma. Okay, the stroma and the basal cell carcinomatous cells, they talk to each other, okay, and they live in a what do you say, symbiotic way. So stromal dependency is something which is peculiar, very much peculiar, and this is seen in case of basal cell carcinoma, and this is the major reason why they rarely metastasize and they keep themselves only to the point where they have formed. Okay, a word regarding this nevoid basal cell syndrome, which is also called a Gorlin syndrome. Okay, it is an autosomal dominant. The abnormal tumor suppressor gene is seen on chromosome number 9, similar to that of your Ferguson's syndrome. Okay, what they have previously asked is regarding the specific phenotype. Okay, what's the phenotype of this nevoid basal cell carcinoma syndrome? Yes, you have multiple basal cell carcinomas, but the phenotype is very peculiar. You see, they have an overdeveloped supraorbital ridge. Okay, they have broad nasal roots, as you can see in this diagram. They will have a broad nasal root. They will have hypertelorism. They will have high bifid ribs. They can have scoliosis. They can have brachymetacarpals. You see, small metacarpals. Okay, they will have palm armpits. They have molar odontogenic cysts. So these specific phenotypic features you have to remember regarding this nevoid basal cell carcinoma syndrome. You see, 90% of these patients, they develop multiple basal cell carcinomas. Okay. Histopathologically, these basal cell carcinoma, the pathognomonic feature is the palisade-like arrangement. You see, these basal cell carcinomas, they're arranged like a palisade or a fence. Okay, these cells. And that is how even their nuclei also appear in a palisade arrangement. Okay, there are few types of these basal cell carcinomas, which are nodular, superficial, and infiltrative. An important thing that you have to remember is this palisading is characteristically absent in case of infiltrative variant. Okay, in infiltrative variant of basal cell carcinoma, out of the three, which is nodular, superficial, and infiltrative, this palisade arrangement is not seen. Fibroepithelioma of Pincus is a rare variant of basal cell carcinoma, which is seen on torso and extremities, and they are polypoidal. So the polypoidal basal cell carcinoma, the other name is fibroepithelioma of Pincus. Coming to the treatment of this squamous cell carcinoma and basal cell carcinoma, there is no stage grouping. That is why when you have seen that these cancers are there and they are regional disease, okay, mostly you will go for a wide local excision, and the margin that you give is 4 to 6 millimeter for a low risk patient and 1 centimeter for a high risk patient. I will just let you know who are a low risk patient or who is a high risk patient in the next coming slides. But as of now, just remember, for a low risk patient, 4 to 6 millimeters of margin for a squamous cell carcinoma or a basal cell carcinoma is sufficient. However, a 1 centimeter margin is advised if it is a high risk patient. Okay, if the lesion is very much small, or it is near to the angle of eye or a nose, or a part of the body wherein you cannot give a good margin, or wherein you cannot sacrifice that organ, let us say, then you can go for what is called Mohs micrographic surgery. Okay, you can also try electrodissection, cryotherapy. You have topical immunoquimod or 5FU. You have photodynamic therapy, and sometimes few centers they treat the patient with primary radiotherapy as well. Okay, but however, wide local excision is the most important treatment modality. If there are lymph nodes, you go with the therapeutic lymph node dissection of the nodal basin. There is no role for sentinel lymph node biopsy in case of squamous cell carcinoma or basal cell carcinoma cutaneous. Okay, in mucosal squamous cell carcinomas and all, you can do similar to that of your penile squamous cell carcinoma also, which is considered mucosal. Okay, this cutaneous squamous cell carcinoma, there is no role of sentinel node biopsy as of now. Okay, so I told you that I will let you know what is a low risk or a high risk patient in case of squamous cell carcinoma or a basal cell carcinoma. In case of squamous cell carcinoma, you have to remember few areas. Okay, there is something called an H area. Okay, and you have something called an M area and an L area. Okay, H area is a high risk area. Okay, these are the mask areas. High risk areas are the mask areas. Okay, that is the central face, your eyelid, your eyebrows, periorbital nose, your lips, that is cutaneous and vermilion, your chin, mandible, preauricular and postauricular skin, okay, your temples and your ear. These are mainly the mask areas of face which are considered a high risk area, okay, along with your genital, hands and feet. Genital, hands and feet. So these are all the H areas or high risk areas. Then what are these M areas? Okay, which are of medium risk or intermediate risk. These are forehead, scalp, neck and pretibia Okay, low risk areas are your trunk and extremities, excluding your hands and feet. Okay, and trunk and extremities. Okay, that's what they have said. So trunk and extremities excluding your pretibia, hands and feet, nail and ankles. Okay, so having understood what are these H, M and L, so now you see, if you have a lesion which is less than 2 centimeters in the L area, it is a low risk. Okay, is the same lesion, if it is more than 2 centimeters, it is high risk. In case of M regions, if the lesion is less than 1 centimeter only, it is a low risk. Otherwise, it is a high risk. Okay, lesion of any size in H area is a high risk lesion. Okay, so this is the importance to know what are those areas of L, M and H. Okay, so in L areas, if the lesion is less than 2 centimeters, it is a low risk. Otherwise, it is a high risk. Okay, in M areas, less than 1 centimeter is a low risk. Otherwise, it is a high risk. And any size lesion in H area is a high risk. Another one more important point that you have to remember, which has been included in the recent NCCN, is any lesion which is more than 4 centimeter. Okay, more than 4 centimeter, whether it be L, whether it be M or whether it be H, these are considered highest risk. These are considered highest risk. Okay, more than 4 centimeter. Okay, similarly, other features that will categorize the patient either as low risk or a high risk are your borders. Okay, well defined border, low risk, poorly defined border, high risk, understandable. Okay, primary versus recurrent, A primary is a low risk and a recurrent is a high risk, understandable. Presence of immunosuppression is high risk. Presence of prior radiotherapy or a rapidly growing tumor or presence of neurological symptoms, these are all high risk features. Poorly differentiated is a high risk feature. Okay, important point that you have to remember are these special histopathological subtypes: acantholytic adenosquamous producing mucin, desmoplastic and metaplastic. These are all high risk features. Okay, important point another here that you have to remember is the depth of thickness. This table I have taken from your Sebiston, okay, wherein they have mentioned 2 millimeters, or they have mentioned regarding the Clark's level. But however, if you see the recent NCCN, okay, depth of invasion of more than 6 millimeters alone, they have given as high risk feature. Okay, so while answering your question, you better read the question properly and try to understand whether this question has been framed from Sebiston or recent guidelines. Okay, if you feel that this question might have been framed from Sebiston based upon looking upon the question format, okay, etc., then you can safely put 2 as the answer. However, according to NCCN, the depth of or the thickness of the lesion more than 6 millimeters is alone considered high risk. Okay, you know anyhow perineural lymphatic or vascular involvement is a high risk feature. Okay, in case of basal cell carcinoma, also the low risk and high risk are almost the same, not much of a difference. Okay, so this completes even your squamous cell carcinoma and your basal cell carcinoma. So next, let us go ahead with the other non-melanomatous skin tumors which have been asked quite a few times in your examination. I'll be very brief with these tumors because not much you need to know. Few most important points, if you know, this is sufficient for your clinical practice and also for your management, and also in the what do you say, your competitive exams. Okay, so coming to your Merkel cell carcinoma, it is a rare tumor, but it is locally aggressive. Okay, it is relatively radiosensitive. This is one point that you have to remember. Malignant melanoma is not at all radiosensitive. That is why adjuvant RT is considered in few patients. That's all. Primary radiotherapy is never given. Okay. However, in case of squamous cell carcinoma, sometimes primary radiotherapy can be given. Merkel cell carcinoma is relatively very radiosensitive. Okay, the term Merkel cell itself says that the Merkel cell carcinoma is of Merkel cell in origin, which is a neuroendocrine cell. Okay, so these Merkel cells, they belong to this Epud system of cells, and these are basically the mechanoreceptors. So basically, they are present in the dermis only. Okay, though we are discussing them as a cutaneous malignancy. Okay, and you know that cutaneous tissues are formed by epidermis and dermis. Since they are arising from dermis, we are considering them in this topic of cutaneous malignancies. Okay, but they don't arise from epidermis, they arise from dermis. Okay, and in histopathology, one important feature which differentiates them from most of all other tumors is the presence of this Grenz zone. You see, this is that Grenz zone. This is that Grenz zone. What is this Grenz zone? This is a uniform lucid zone which separates the tumor from epidermis. This is to say that this doesn't arise from the epidermis rather than it arises from the dermis. Okay, it is more common in males and in white population. 30% is the lymph node involvement risk. Okay, and there is an association of this Merkel cell carcinoma with Merkel cell polyoma virus, which is a double-stranded DNA virus. So this Merkel cell carcinoma is associated with Merkel cell polyoma virus. It is a double-stranded DNA virus. This double-stranded DNA virus is also important. This has been asked previously in one of the examinations. Okay. And you see, these Merkel cell carcinomas are also associated with immunosuppression, that is mainly with seen in patients of AIDS or patients on transplantation, and also UV irradiation. Okay, the treatment for this Merkel cell carcinoma is wide local excision, and here the margin is 2 to 3 centimeters. 2 to 3 centimeters. You can also do a sentinel node biopsy similar to that of malignant melanoma, and adjuvant RT is given in appropriate cases. Okay, coming to dermatofibrosarcoma protuberans, it is a low grade, low metastatic potential, but locally aggressive. It is locally aggressive. It is common in blacks. Merkel cell carcinoma was common in whites. Yes, it was common in white population. Whereas dermatofibrosarcoma protuberans is common in blacks. Males and females are common. The incidence is same, almost the same. Whereas Merkel cell carcinoma was common in males. Okay, important points that you have to remember in dermatofibrosarcoma protuberans is an association with this translocation 1722. Okay, 90% of the patients of this DFSP, they show this translocation of chromosome 1722. And this is the reason why imatinib has got a role in the treatment of this dermatofibrosarcoma protuberans. Another important point that you have to remember is that the presence of supernumerary ring chromosomes is what differentiates this dermatofibrosarcoma protuberans from most of the other tumors also. Okay, so the supernumerary ring chromosomes are also seen in few of the germ cell tumors and also like your seminomas, etc., etc. Similarly, you also see the supernumerary ring chromosomes in dermatofibrosarcoma protuberans. Mostly they are mistaken for scars, and they usually arise from dermis, and they are flesh-colored nodules. As you can see in this image, they're usually confused with scars, and most of the people, they tend to misdiagnose them and they leave them. Okay. Another important question that was previously asked was regarding this Bednar's tumor. So a pigmented dermatofibrosarcoma protuberans is called a Bednar's tumor, is the other name for Bednar's tumor. And these dermatofibrosarcoma protuberans, these are CD34 positive. However, they are negative for factor 13A and stromilysin. Okay, the treatment is same, wide local excision, and the margin that you give here is 2 to 4 centimeters. Merkel cell carcinoma 2 to 3 centimeters. Here it is 2 to 4 centimeters. Okay. Coming to the extramammary Paget's disease, as you all know, not much to be added into this. It is the adenocarcinoma of the apocrine glands of the skin, which has mainly a horizontal spread. Okay, they're mainly seen in perianal region, vulva and scrotum, since it is extramammary. Okay, they present mainly as erythematous plaques with areas of crusts, scaling and itching. The common differential diagnoses are your eczema, fungal infection and bacterial infection. Okay, and 15 to 30% of the cases are associated with internal malignancy. This is what you have to remember. In extramammary Paget's disease, EMPD, okay, internal malignancies are seen in almost 15 to 30% of the patients. So complete surgical excision is the standard of care, and sometimes a topical immunoquinone for 12 weeks is an accepted alternative treatment. Coming to the cutaneous angiosarcoma, there are various other names for this cutaneous angiosarcoma. You can call them malignant hemangioendothelioma, hemangiosarcoma, and lymphangiosarcoma. You see, these are the other names for cutaneous angiosarcoma. Okay, they are not different conditions. They are all the same conditions. Okay, and however, there you have 4 variants to this. You have angiosarcoma of head and neck. You have lymphedema associated angiosarcoma, which is commonly called Stewart-Treves syndrome, and you have radiation associated angiosarcoma, and you have epithelioid angiosarcoma. Okay, the treatment of this angiosarcoma mainly is excision. Okay, in most of the above mentioned 4 variants, excision is the treatment of the condition. However, sometimes post-excision you may need to give radiation also, except for radiation associated angiosarcoma. Okay, so this completes mainly your cutaneous malignancies. However, this last few 3 to 4 slides alone, I'll quickly rush through the benign skin lesions that you have to remember, because now the format has changed, and few of the times you have been given few images to identify, right? So these benign skin lesions which have been extensively discussed in your Bailey, I have taken them out, and few I have presented to you such that you can remember them just as a marker or identifying lesion that you should not miss in your exam. You see, you have something called the basal cell papilloma, or a seborrheic keratosis, or a senile keratosis, or a verrucous senilis. So this is the one: basal cell papilloma, or a seborrheic keratosis, senile keratosis, or a verrucous senilis, which is a pigmented hyperkeratotic lesion. You see, this is a pigmented hyperkeratotic lesion. This is formed from the basal layer of epidermal cells, and it contains melanocytes. It contains melanocytes. Though you call it a seborrheic keratosis, yes, it is hyperkeratotic, still it contains melanocytes. This is what you have to remember. Basal cell papilloma, though it is called a basal cell papilloma, this basal cell, since it is basal, it should have melanocytes. Okay, this is how you can remember regarding this basal cell papilloma, or a seborrheic keratosis, or a senile keratosis, or a verrucous senilis. Okay, then you have papillary wart, or a verruca vulgaris, which is HPV related. This is one most common condition that most people you understand. Okay, but what I want you to remember is regarding the freckle or the epiphysis. This is a lesion. As you can see, they appear has some few hyperpigmented lesions, right, over the face, mostly on the bridge of the nose. Okay, the importance of this lesion is they have normal number of melanocytes. They have normal number of melanocytes, but they have larger number of melanin granules. Melanin granules alone, they are in larger number. However, the number of melanocytes remain the same in case of freckles or epiphysis. Okay, going ahead with the other benign skin lesions, you have some nevus. It could be a junctional nevus, a compound nevus, or an intradermal nevus. As the name itself suggests, you see, junctional nevus, in this junctional nevus, you have the proliferation of these nevus cells or the melanocytes at the junction level only. That means at the dermoepidermal junction only. Okay, so they don't go into the dermis. They are at the junction. Compound nevus is an elevated junctional nevus. It is an elevated junctional nevus. You see, the same junctional nevus, it will be larger in size and it will be elevated. It will be elevated mostly, and it will have very less component in going into the dermis. Whereas the intradermal nevus is one wherein you don't have an epidermal component at all. Whole of the component is in the dermis, but still it is, since it is large, it has elevation. Okay, so these are the three kinds of nevuses that you have to remember: the junctional nevus, compound nevus, and intradermal nevus. So intradermal nevus, there is no junctional proliferation, only cluster of dermal melanocytes. Mind you, all of them are benign skin lesions only. Okay, you have something called Spitz nevus, which is also called a juvenile melanoma. It is called Spitz nevus because here the nevus cells, they are present in vertical fashion. As you can see, they are vertically fashioned. Okay, here you have something called spindle cell nevus, wherein the nevus cells are spindle in shape. You have a halo nevus, wherein this is the perfect example of this halo nevus. Okay, you have a nevus followed by a halo around it. This is mainly due to an antibody response to these melanocytes. You have nevus speleus, which is a speckled lentiginous nevus. This is it. Okay, and you have cuff-like spots, which are coffee-colored macules, which are more commonly associated with your neurofibromatosis type 1. And other few that you have to remember is McCune-Albright syndrome also. So cuff-like spots, yes, neurofibromatosis type 1, but also McCune-Albright syndrome. Okay. Then you have few spots, which are the Mongolian spots. You have nevi of Ota and nevi of Iota. Okay, these Mongolian spot, you already know, these are congenital blue-gray macules. They are mainly seen in the sacral skin. This is the sacral area wherein you find them. Okay, and these usually regress by the age of 7 years. Okay. Apart from them, the two other lesions that I want you to remember are these nevi of aorta and nevi of aorta. So this you can remember, like in aorta, you don't have I, no I, no I in aorta. Okay, that is to say, these nevi of aorta, these are basically dermal melanocytic hematomas. Okay, these hematomas are mainly blue green color. They are macules and they are mainly seen in the trigeminal V1 and V2 dermatomes. Okay, V1, V2, and V3 are these are the dermatomes of the trigeminal nerve that you already know. Okay, V1 and V2, they will be in and around the eye. So that is the reason I asked you to remember aorta is not near the eye. Nevi of aorta alone is near the eye. This is near the eye. So these are the dermal melanocytic hematomas, okay, which are in the distribution of the trigeminal V1 and V2 dermatomes. Nevi of aorta, no eye. Okay, so these are the same dermal melanosis or the dermal hematomas. These are seen in the shoulder region. Okay, so this is the thing that you have to remember. So the other few points that you have to remember are your trichoepithelioma. These are skin colored nodules. These are mainly seen in the nasolabial folds. Clinically and histologically, they are similar to basal cell carcinoma. They will be looking like basal cell carcinoma. Okay. Pilomatrixoma is a calcifying epithelioma of Malherbe. These are benign hair matrix cell tumors. They often calcify and 40% are under the age of 10 years. So these 3 points you have to remember regarding pilomatrixoma. Okay, it's also called calcifying epithelium of Malherbe. That is why they calcify. Okay, these are benign lesions and they are seen in mostly less than 10 years of age. Tricholemoma is one. Nevus sebaceous of Jadson, the other name. It's also a hematoma. Not much of your importance, just know the name of the lesion. Tricholemoma is also called nevus sebaceous of Jadson. Okay. Adenoma sebaceum, you already know, is associated with tuberous sclerosis and von Willis disease. Okay. Rhinophema, this important thing that I want you to remember is rhinophema is an end-stage sequelae of nasal acne rosacea, and you have occult basal cell carcinoma in 3% of the patients. In rhinophema, 3% of the patients will have occult basal cell carcinoma. Okay. Ecrine poroma, also called papillary syringoma, and cylindrioma, which is also called turban tumor. The clinical details of them are not very important for you. In this slide, it is sufficient for you to remember rhinophema alone. Okay, so this completes the discussion regarding your cutaneous malignancies, and I hope this session helps you to answer, to build up your concept regarding your cutaneous malignancies, and also help you to answer most of the questions in your examination. Okay, thank you.